Hi, Gibson, David Ferreira, and we're coming to you live from ESC 2024. Important issue, common issue, and that is, do we really need to be NPO before our catheterization procedure? So, David, talk to us a little bit about what you did in your SCOFF trial.
Yeah, so I mean, cardiac procedures we perform every day on our patients, device procedures, coronary procedures, millions of patients worldwide undergo these procedures. This is bread and butter cardiology. And so the management of these patients is incredibly important. At the moment, anesthetic societies recommend fasting for these procedures that require conscious sedation, and that's 6 hours of food and 2 hours of clear liquids. But the question is, do we really need to? There was a recent randomized control trial published in abstract form, which removed fasting requirements and showed non-inferiority. And so we sought to perform our own multi-center, randomized, prospective trial to investigate this. Do we really need to fast patients? What happens when we remove fasting requirements? Is it any worse? Is it any better? And so that's where we are really excited to present our results for the SCOFF trial.
And how many patients did you randomize? Talk to us a little bit about the design.
Yeah, so we had recruitment across 6 sites with procedures performed at 3 sites across different health districts in Australia. And we had just over 700 patients, 716 patients randomized 1-to-1 to a routine strategy of fasting as per anesthetic guidelines or completely removing fasting requirements. No specific recommendations in terms of food intake. And we actually encourage patients to have their regular meals and eat and drink as they pleased. And this was a prospective, randomized, open-label, blinded endpoint design. Of course, we cannot blind patients to know whether they're eating or drinking. And equally, we can't blind caregivers. We can't blind nursing staff. They need to know whether to enforce fasting or not. So we couldn't blind them either. But we did have blinded endpoint adjudication with 3 physicians who reviewed all primary and secondary outcomes for both groups, obviously not aware of treatment assignments. This was a non-inferiority trial with a Bayesian design. And the previous trial I talked about, Chow Now trial, we used a primary composite outcome with event rates from the Chow Now trial with an absolute risk difference, non-inferiority of 3%, and investigated for non-inferiority from that. Yeah.
And what kind of patients were these? Were they elective or urgent or a mix? Because that's really going to determine, the event rates and whether you're going to see perhaps superiority.
Definitely. And so a few important points. So we included both inpatient and outpatients within this trial. We included both elective patients and patients with acute coronary syndrome. So we also included both inpatient and outpatient device-related procedures. It is important to note the exclusion criteria. We obviously excluded those undergoing structural cardiac interventions, those who did require a general anesthetic anyway. And when we designed this trial, we didn't have any data apart from Chow Now. And so in the interest of patient safety, we also excluded cardiac resynchronization therapy, which we know can be long, complex procedures, as well as planned calcium modification. And, there is a small, albeit serious risk of potentially going to cardiac surgery. Though the risk is small, we thought it would be better to exclude the patients with the current evidence that we had. But we did not exclude patients based on body mass index. We did not exclude patients based on age or weight. And so all comers were included, and we did have some elderly and quite diverse population.
And what did you find?
We basically found that for a primary composite outcome of aspiration pneumonia, hypotension, hyperglycemia, and hypoglycemia, that this occurred 19.1% in the control arm, the fasting arm, and 12.0% in the no fasting arm. And this correlated to an absolute risk difference of 7.1%, a number needed to treat of just over 14. And so this really demonstrated and confirmed with our Bayesian priors both non-inferiority, but also confirmed superiority. And so an exciting and I think a very important and clinically relevant result.
Did you have hangry as an endpoint? Were people hungry and angry? Did you look at quality?
We did as well. And so we did use a pre-procedural fasting questionnaire, actually validated for cataract procedures, but of course there wasn't a specific one for cardiac procedures. And we also found a statistically significant improvement in patient satisfaction in the no fasting arms. Not only did it reduce the composite endpoint, it also improved patient satisfaction.
So is this enough? I mean, should it change care?
Look, I think this is enough. And the one thing I would say is, thankfully, SCOFF is not the only trial. Recently this year, we have multiple other randomized trials, albeit single centers, but we have the TONIC trial. We have FAST CIED published a few years ago. We have the Healthy Heart Diet trial. We have, the CORO NF. We've got other other single center randomized controlled trials, all showing a consistent result that removing fasting requirements does not appear to be associated with adverse patient outcomes, and has consistent improvements potentially also in patient satisfaction. And so I think the weight of the evidence has now shifted against recommending fasting for these procedures.
Wow. Well, this is important. I mean, this is a common issue we face every single day. Dave, congratulations to you and your investigators on a well-conducted study. I think hopefully it will change practice. Thanks for joining us today, and thanks to all of you for joining us here live from ESC 2024.
Thank you very much for the opportunity.